Thank you so much. Thank you to Total Health for the chance to be here to talk with you all today. And thanks for the opportunity to just go out there and take in those breaths of fresh air. I love it. And so thank you for the motivation to do that today. So I get to talk about managing toxicities in novel agents in heme malignancies. And this used to just be, all right, we've got chemotherapy and that's about it. And this actually gets to be a more and more interesting topic as the years go along. Since the other session was about some updates from ASH, I will try to throw those in there and go through that as well. So here's disclosures, and then off-label, we'll talk about PVEC in BPDCN, not yet approved, although if I were to read the tea leaves, maybe we'll have that option in the future. And objectives-wise, just to talk about these toxicities, how to manage them, how to recognize them in these medicines for hematologic agents. And so we'll start with cases. I always like to bring it back to the patients that you may see potentially next week. And a 72-year-old man referred to you from the dermatologist due to progressive cutaneous nodules on sun-exposed skin over the past 3 weeks. Exam is notable for multiple purpuric nodules that are violaceous and up to 4 centimeters on the arms and back. No palpable adenopathy or HSM noted. Labs show white count 9.1, hemoglobin 9.2, platelets of 74, and here are some of those skin lesions. And again, interestingly enough, in contrast to CTCL, where UV light can actually treat it, this is characteristically a condition where you see it more often on sun-exposed areas because UV light is thought to play a role in the pathogenesis of this disease. Some of the mutations happen in the skin. They go back to the marrow. Andy Lane did some great work on that if you're interested in it. But these are what some of these nodules will look like. A biopsy of the skin and the bone marrow both identify blastoid cells at 40% in the marrow, with IHC revealing positivity for CD123, CD4, CD56, and TCL1 confirmed on flow cytometry, negative for 34, MPO, and CD19, so diagnosed with BPDCN. So I know an uncommon malignancy, but at least some things that we get to talk about in terms of medications that are novel and novel toxicities. Less than 1% of heme malignancies, striking male predominance, and it's thought to be that homozygosity plus the UV exposure is the combination of the pathogenesis there, median age 60s to 70s, and 10 to 20% will present with a concurrent or prior heme malignancy, so MDS, CMML, things like that. So don't be surprised if you see 2 of these things at the same time. In the upper left, some of the pathophysiology, upper right, those violaceous nodules that change very quickly. You'll probably get a lot of these patients from the dermatologist, but they can also present looking like an acute leukemia as well. So do 2 separate things to keep on the radar. CNS disease is common. Put in your head that this is a little bit like ALL. They need a diagnostic LP at the time of presentation, follow for it, and strong proponent of intrathecal prophylaxis. Bottom right, as we'll talk about in a moment, TAG, also known previously as SL401, chemotherapy, transplants, and some trials. In terms of diagnosis, this is one thing that I think is helpful to take away because these can be hard to diagnose. I think we've heard before the 1, 2, 3, 4, 5, 6, 123, CD4, CD56. It actually takes 4 out of the 6 markers to diagnose it. So that gets you 3 of the way. And so TCL1 there, I'm just going to try to put this into your brain and you'll remember it. This isn't officially what it stands for, but I call it that cutaneous leukemia 1. Just so I remember that this leukemia-like thing that presents in the skin, that cutaneous leukemia 1 is the next marker after 1, 2, 3, 4, 5, 6. That will help you make the diagnosis. And in terms of clinical presentation, almost all patients, especially up front, present with skin lesions. If you don't see skin lesions, be very surprised. But if you see somebody or hear a story, they've got leukemia and they've got skin lesions, maybe this is leukemia cutis, have this on your list. Say to the pathologist, hey, how about a TCL1? How does the CD123 look on this? It is present in all patients with BPDCN. You can also see the CNS, again, about 20 to 30% of the time at presentation, hepatosplenomegaly, extranodal lesions, lymph node-based disease, and bone marrow. In the bottom left, a helpful table for just the steps of working through how do we diagnose these patients. And you can see, based on the involvement of skin, looking with a PET scan for that extracutaneous lesions, bone marrow biopsy, checking that CSF. And again, 4 out of those 6 markers, list them again there. There are some other ones. TCL1 is the easiest one to get. That's why I just really focus in on that one to cut through the noise. That cutaneous leukemia one is a helpful way to remember it. So CD123 therapy in BPDCN has led to a significant improvement in our ability to treat these patients. Again, this is a 60 to 70-year-old on average time of diagnosis, and so giving them aggressive induction chemotherapy is not always the easiest thing to do. If you're thinking about it, ALL-based therapy generally does better than AML-based therapy, but again, if they have concurrent CMML, for example, can make you lean in the direction of myeloid induction. But skipping to these novel agents, Tagrascofusp, or TAG for short, has a diphtheria toxin payload. You give it on days 1 through 5, every 3 weeks. First cycle generally is always inpatient, and that's because you need to monitor for all of these things: drop in albumin, rise in creatinine, weight going up, blood pressure going down, and then it's at its extreme end, capillary leak syndrome. And that is the most characteristic side effect that we all think about, reason we give it inpatient. And so when you're giving this, if you give it at your institution, go slowly. There's no rush to get the 5 days in 5 days. Take your time, make sure you get the first cycle in. If you do, you're able to get the rest of them in, usually outside the hospital. Patients tolerate it great. It's just this first cycle when that inflammation can get stirred up. But over on the right, I'm going to contrast that with pivekimab sunirine, I believe, soon to be approved. There's going to be some updates around ASCO, but embargoed for now, where it's got a different payload, this IBD for short, payload that alkylates DNA, so a little bit less toxic than the denileukin diftitox. If you think about the CTCL use of that medication, you know about all of those side effects as well. And so yes, is CD123 on the endothelium? Some of this capillary leak was thought to be related to that, but here's a 123 agent, and so far no capillary leak has been seen with this agent. And you can see, again, cross-trial comparisons, always hesitate to do so, but great responses in both of them, over 70% likelihood of response. But this medication, outpatient therapy from the start, given on day 1 every 3 weeks, and so far much less toxicity seen. Lower extremity edema around cycle 3 to 4, keep an eye out for that. But again, I think this will really help to extend the treatment of BPDCN farther and farther out into the community, keeping patients where they live as opposed to having to come in, get this first cycle of TAG in a hospital-based setting. So capillary leak in all TAG trials was 55%. Most of it was grade 1-2 and did resolve, meaning you just kind of wait, get that creatinine normalized, infuse some albumin so that it's up high enough so that you can give the next dose. Again, go slow on that first cycle through if you're doing it at your institution. If you keep pushing, that's where you can get into these grade 4 and even in the trials, grade 5 events where before some of these hold parameters around albumin, blood pressure, weight gain were instituted. That's when those were seen. Management and prevention, again, hold if albumin under 3.5. Yes, you can give albumin if it drops even by 0.5 grams per deciliter. Put in albumin, get it up, and as soon as it's back to target, then you can go ahead and give the dose. Follow that daily weight closely, exam for edema, monitor blood pressure. Find it helpful to write these all into that chemotherapy plan that for most all of us now is electronic, and that really helps to guide the nurses on when to safely give it, when to hold, when to reach out to you. Oops, one more thing. The last thing I want to say on this before going to case 2 is prevention of capillary leak might just be using a medicine that doesn't cause it. So more to come on that. Y'all can look for that in a couple months. Hopefully we get that option available. Case 2, 69-year-old woman with AML presents to the clinic with a drop in counts after therapy with HMA-VEN as initial induction. Bone marrow biopsy confirms progression with 55% blast that remained positive for KMT2A rearrangement, as well as an NRAS mutation with a VAF of 23% on NGS. And she started on revumenib monotherapy. And revumenib, if you're not familiar, is a menin inhibitor. And in terms of ASH updates, since I get to speak a little bit to that, there was a whole session on menin inhibitors in AML at ASH this past time. There are a number of them that are all kind of focused on this same target of menin. Revumenib, one of the things to mention is you do need to be aware of CYP3A4 inhibitors, and so again, most patients with AML are going to be on an azole, so dosing there, just make sure you take a check there, as well as QTc prolongation. Those things are not true of all of the menin inhibitors, though. Case 2 continued. Patient developed a fever day 7 at home and was admitted. She reported cough and dyspnea, 93% on 4 liters, labs as shown. I'll go through those in a moment. Chest x-ray revealed bilateral pleural effusions and an enlarged cardiac silhouette. Respiratory viral panel cultures negative. And so in terms of this white count, you can see it going up each day, 18, 22, 40. That ANC rising. The blast sticking around. And this is one of the things I'm going to loop back to in terms of this diagnosis in patients with menin inhibitors. It's not identical to that diagnosis that we've seen in other targeted agents. LDH going up, usually the ferritin will follow and other inflammatory markers. Anyone want to take a guess on diagnosis here? I think I might have seen it mouth, but yes, differentiation syndrome. All right? Menin causes differentiation. So really, when you think about it, acute leukemias are diseases of failure to differentiate. Right? The cells are being produced. It's not like MDS where they can't make cells at all. But instead of a blast turning into that, metamyelocyte, myelocyte, and then outwards to whatever functional cell it's going to be, it stops differentiating. And so that's why a lot of these targeted agents that now start finding the true pathogenesis of leukemia are leading to differentiation syndrome. A few things to point out, and this example is with ziftomenib, another one of those menin inhibitors, but revumenib, you can supplement it there as well. Point out a few things. One is menin is upstream of FLT3, BCL2, IDH. So some of these other targets, you can see IDH here, menin happens beforehand. You can see FLT3 all the way down here, and this is why FLT3 oftentimes leads to relapse of FLT3 negative disease when you're using your midostaurin and other FLT3 targeted agents. You can see that it's KMT2A rearranged, not duplicated. KMT2A rearranged AML, not partial tandem duplication, or NPM1 mutated. And so this accounts for about 35 to 40% of AML. That's why there's so much enthusiasm here. This is about almost getting to half of AML that we're going to be able to use these agents in and continue to be encouraging in terms of their efficacy. When we use these agents, important to note that can you combine them with other downstream targeted agents? Possibly. Those studies have not yet been done. Intriguing question, get that often. But that's why, at least in terms of the frontline studies, FLT3 NPM1 co-mutated disease has not yet been included in the frontline studies, but it is included in the relapse refractory studies. So we do know that, for example, gilteritinib and ziftomenib combination works well and able to be used without concurrent cytoreductive chemotherapy. So differentiation syndrome in menin inhibitors, here's how it's different. Most of us, at least I do, when I think about differentiation syndrome, I think ATRA and arsenic with APL. You give these meds and you see a bunch of neutrophils, fever, a lot of the similar symptoms, the pleural effusions, pericardial effusion, kidney injury. And so a lot of these symptoms are the same, but menin inhibitors, because it is farther upstream, you can still see a fair amount of blasts. And this is really, really hard to differentiate sometimes. Is this progressive disease or is this differentiation syndrome? So one takeaway I would ask you to have with menin inhibitors is, just like I said with TAG, be patient. Don't give up on this in the first cycle. You probably can take another run at it. And I'll show you an example here. This was presented at ASH, and a little bit different take on it in terms of the question of relapse versus response. So this is a 60-year-old, newly diagnosed NPM1 mutated AML, zifto and 7 and 3. Of note at ASH, the overall response rate of this combination was 100%. 100%. Pretty remarkable. That's what these medicines are doing. Really, really exciting stuff coming. And again, getting through that first cycle differentiation, these are things you're going to be able to give, whether you're in a major academic center, out in the community, oral meds, once you get them through that first cycle, really tolerated well. But in this patient, screening marrow had 8% blasts, 34 negative, NPM1 positive. They had a day 21 marrow that showed 30% blast, 34 positive, NPM1 negative. And you can see here, here's the NPM1 negative here, 34 starts to emerge. And thankfully, the investigators, we chatted about this case quite a bit and said, is this progressive disease? Went from 8% to 30%. Sure looks like it's moving in the wrong direction, but look what happens at day 35. Back down to 1%. Nothing else done, counts recover, they entered a CR. So these menin inhibitors can turn disease into blasts that aren't disease blasts. You can see them in the periphery, and so that's why in this example, you keep seeing blasts in the periphery, patients getting pericardial effusion, pleural effusion. I've seen it already with revumenib a couple times. You get the call. I started giving it to them a couple weeks ago. They're already starting to progress through it. Man, these medicines are horrible. And so I would just caution, it doesn't mean that some people progress through. Don't get me wrong, they definitely can. But before concluding that, make sure that they aren't just having differentiation, because that means it's working and they're likely to have an excellent response. So management of DS with menin inhibitors. Yes, we do start steroids. In general, they're less effective than that ATRA, ATO, APL differentiation syndrome. Similar with IDH. IDH inhibitors I put over in the basket of APL. This is different. Yes, we start steroids. Don't seem to work as well. Cytoreduction, yes. If you see that white count go up, at least hydrea, I'm a big proponent of just putting in some Aracy, usually a gram per meter squared, again, if they're able to tolerate it. Holding the menin inhibitor, just like I said with TAG, be patient. If you're pushing stuff over very, very quickly and they're differentiating, holding it can slow it down, just like we would in that APL patient that has their white count going up to 40. Hold off on the ATRA and the ATO. You get them through that first cycle, and guess what? We're looking at 97% in APL landscape that they're cured. I'm not going to claim that for KMT2A rearranged yet, but I hope that we see that with these frontline trials happening, and just emphasizes the importance of getting through that first cycle. Realized blast could be early DS and not progression. So look for disease-specific markers. Now in this example, they use an NPM1 stain, and I acknowledge in real time, when you've got a patient with a rising white count and a lot of blasts in their bloodstream, it's a little bit hard to wait for an NPM1 stain that probably isn't done routinely. And so look for the immunophenotype on flow. This is one of the things that can be helpful. Draw a peripheral flow on that patient that you think is either progressing or having differentiation syndrome, and look and say, is there a leukemia-associated immunophenotype? Is there something that characterized their disease before? And if the pathologist says, yeah, all of the markers seem to be the same, but now they're CD33 negative where they were positive before, or something else that's different, have in your head that this might not be progression, this might be differentiation syndrome. And finally, this is what I'm suggesting for revumenib. Now that it's out and FDA approved, I caution against using it as monotherapy. If you're wanting to start in on it, first cycle, I would think about at least some low-dose Aracy, that outpatient 30 milligrams per meter squared type of thing, to help reduce that blast burden, and especially if they've got significant blasts in the marrow. If you're looking at a patient with 80% blasts, KMT2A rearranged, and you're going to start them on revumenib monotherapy, the likelihood that differentiation syndrome is going to be hard to control is significant. So I would start out with something cytoreductive to combine with it. All right, good. Now we'll go to something that's not leukemia-based. For those of you that lean away from those things, we're going to go to a 62-year-old woman, relapsed lymphoma, large cell lymphoma, treated with day 8 of glofitamab. Interestingly, so StarGlow, and they've got glowworm and all that, and ASH was updated, glofitamab plus GemOx. So if you've got a patient going into to your glofitamab bispecific therapy with a decent burden of disease. Adding in chemotherapy, decreasing that burden of disease can be helpful for decreasing the side effect that we're going to talk about here. And so again, just trying to put in some of those ASH updates here and there. Past history, diabetes, hypertension, baseline creatinine 1.3. 24 hours after her day 8 dose, she develops fever, oxygen requirement 4 liters by nasal cannula. On exam, she's a little bit tachypnic, heart rate's up at 120, blood pressure a little bit soft, but responded to fluids. White counts 2.5, hemoglobin 10.2, platelets 155, and a chest x-ray shows diffuse infiltrates without significant effusion. So cytokine release syndrome, I won't even make you guess because you said, all right, that's the side effect here. The reason I think it's helpful to continue to talk about it is as these medications become, one, more and more familiar to us, and two, I think as we start combining them with a little bit more cytoreduction, I think we're going to keep seeing the CRS go down. My hope is that this makes it even more easy to access these medicines, farther away from where they so far have been a little bit more limited to the academic multidisciplinary settings. CRS, inflammatory response characterized by cytokines, IL-6 and interferon gamma. And yes, the story is true, the early story of tocilizumab sitting around at UPenn, and they said, how can we address, man, these patients keep going on the vent, and somebody said, hey, my daughter's got juvenile RA, she's on toci for that, I wonder if it would work here, and that's the genesis of use of toci for CRS, first described in the setting of CAR-T, as I mentioned. So bispecific antibodies in lymphoma, myeloma, I always have to check this list because it keeps changing, and that's a great thing. There are more and more of these that are coming to market, more options for patients, but in general, you can see the B-cell lymphoma ones, CD3 by CD20. For myeloma, we do have 2 different targets, BCMA and the GPRC5D, and for talquetamab there. But in general, I call them matchmaker meds. They bring the immune system over, bring the lymphoma over, and say, instead of, all right, go have fun, just get rid of the lymphoma there and enhance the immune response towards these malignant cells. Again, cross-trial comparisons, always lots of caveats, but I just think this is a good summary here. You can see response rates in aggressive lymphoma in the blue, indolent lymphoma in the green. The more solid color is a CR, more light color is a PR. But you can see here, EPCO, glofitamab, mosunetuzumab, significant responses here. Odronextamab include here as well. That one is soon. I think we'll see it out and about as well. Significant response rates here. Great meds, great addition. I oftentimes get the question, where would you use bispecifics in terms of CAR-T? In lymphoma, where CAR-T has shown to be a potentially curative therapy, I do CAR-T first. In myeloma, where so far CAR-T has not had that benefit, I would say that this is a dealer's choice, less kind of clear in terms of, all right, which one would I use first. There is some theoretical concern about exhausting the T cells before you collect for CAR-T, so I do encourage some time span between use of a bispecific and collecting for CAR-T if you use it first. Consensus definition of CRS, it must include fever. And I think that this is really helpful when you're managing your patients with CRS because oftentimes they've got a lot of comorbidities, they've got a lot of other things that could be going on. Infections are certainly on the list as well. Now, if they've gotten steroid, toci, Tylenol, things like that, you may not see that fever. So just know, caveat there. But otherwise, if you don't have fever, question a lot whether it's CRS and start looking for other potential etiologies. It's not defined by cytokine levels. I do find it helpful checking CRP and ferritin in anybody, for example, CAR-T, or if you're treating with somebody with bispecifics at that step-up dosing. I would check in on those inflammatory cytokines. It gives you a little bit of a heads up. If you see that CRP starting to peak, that's probably a patient who follow a little bit more closely. Here's just a graphic that I find is helpful. You can see on the far left, present fever in all of them. Grade 2 goes up to 6 liters of oxygen, hypotension without pressure. As soon as you're on a pressure over 6 liters, then you're grade 3. Again, grade 3 and 4 CRS with bispecifics is thankfully quite low. And so I do think that, again, with a plan for management, one, can you give it in your center? I do think you can. I like to encourage people that yes, I don't think that this is beyond something that you and your team can do, but does it take some planning ahead of time? Yes. Second is, in terms of where you give it, inpatient, outpatient, differentiates a little bit in terms of the initial management. If you're giving it outpatient, I'm a big proponent of having steroid in the pocket, I call it. The old atrial fibrillation days where they had the pill in the pocket, they'd take it and stop atrial fibrillation. This is a little bit of the same thing. You just have some dexamethasone you carry around, they get a fever, I have them take it. And then they can come in, call in, figure out where things are at, but most of the time that successfully manages it. There are some studies also looking at tocilizumab as primary prophylaxis of CRS, again in an effort to make this even easier to give in the outpatient setting and in a more broad community and academic-based setting. In terms of general considerations for CRS management, ferritin, CRP, and serum cytokines support the diagnosis but not required. Tocilizumab, first-line treatment, second-line. Many agents. The one I usually go to if it's not sticking is anakinra, but ruxolitinib also has good activity in this setting. Again, an oral med, so it sometimes takes a little bit longer to get. If you have somebody with grade 2 CRS, bispecific or CAR-T, I'm a big proponent of giving a dose of steroid with that tocilizumab, because one of the things we know is significant CRS predicts for a higher likelihood of significant ICANS. And tocilizumab does not treat ICANS, steroid does. And so if you can decrease those inflammatory cytokines in the CNS ahead of time, some of those cells that are contributing to it, find it helpful to avoid some of those things a few days later. So as you select whether for who's going to get this outpatient versus inpatient, who's more or less likely to need to come in for that weekend visit, what are the predictors for significant CRS and neurotoxicity? One of the biggest is bulk of disease, whether it be myeloma or lymphoma. And so you can see over on the right here, the red is grade 0 to 2 CRS, and it doesn't mean that everybody gets CRS with low metabolic tumor volume. This is of patients that have CRS. You can see that low metabolic tumor volume, almost all of it is grade 0 to 2. So this means no pressors, maybe a little bit of oxygen. This is stuff you can potentially manage outside the hospital or safely get them in. It's this high metabolic tumor volume where you see about 20% of this grade 3, 4 CRS. This is from a CAR study. So again, bispecifics is going to be even lower than that. But tumor burden is a great way to kind of help to predict this. Again, otherwise looking at the characteristic things, performance status, baseline CRP level. If you see a CRP level greater than 100 before you give a dose, keep your eyes out. That's a fairly good predictor for more significant CRS as you start using these in your patients. So here's an approach. There's lots of different ways to skin this. I built this mostly for inpatient use. So you'll notice I don't use the steroid in the pocket here. I might just need to make a third column, but I find that oftentimes the first step into this is, all right, let's at least give a step-up dose in the hospital, get comfortable with it, move to the outpatient setting, but some guidelines and guidance here. And with that, I will pause, and since I get to represent all of heme, happy to take questions about all of heme, a case, ASH, anything you heard about, and appreciate your time and, again, the chance to speak with you all today. Thank you.
One of the last Total Health events in 2024 at ESMO, one of the ESMOs, they were talking about the use or the assessment of gut microbiome in CAR-T. This was really fascinating, of course, shocker to me. Yeah. But I think that there's obviously huge buy-in from oncologists in every specialty about the adjunct of lifestyle. But I was just curious to know what your perspective is in thinking about that as a novel strategy.
Yeah, I think that there's so much to unpack there, so great question. One is, and even in transplant, has been shown to decrease risk of AML relapse, graft versus host disease, treatment-related mortality, that gut microbiome. Now, some of it so far has been correlative as opposed to an interventional. And so that's one of the questions. We know that in transplant, for example, patients that get more antibiotics aren't doing as well, right? We would love to keep them off of antibiotics, but I do think it's there, and one of the, speaking of ASH updates, one of the plenary sessions that I love that they gave some talk to is, it was actually looking at CAR T function based on diet. And this was a mouse model. They're now doing it in humans, but they looked at a variety of diets. They looked at the Mediterranean, a vegan-only, normal feed for the mouse. They called it the Western diet, which I thought was a little bit of a nod to fast food, but it was just the high cholesterol and all that. And then the final one was a ketogenic diet. And they found that levels of beta-hydroxybutyrate correlated not only with T-cell function and gene expression, epigenetic regulation, right? These things that are, we're trying to develop meds to do that, and here just this modification of diet they were seeing in mice, and they found that when they put in the CAR T into these mice with a lymphoma model, it actually took fewer CAR T cells in those that were fed the ketogenic diet. And so it does suggest that the CAR T cells are more effective in the presence of that ketogenic diet. So I think that there's a lot there, and I'm really, really excited that, that there's enthusiasm around it because, of course, of all of the interventions that we talk about, right, novel toxicities, adjusting diet is a fairly low toxicity way to improve function. So that study is now going into humans, beta-hydroxybutyrate supplementation in patients undergoing CAR T cells. So now when I'm admitting patients to the service, I say, all right, we don't know if it makes it too active or you're going to see more CRS, ICANS, things like that. It does seem to potentially impact T-cell function through that epigenetic regulation and limiting T-cell exhaustion. And so it's intriguing. So I say if you want a steak, go for it. But so far not having them eat Crisco. So I think that in terms of the microbiome, yes, I think a lot of enthusiasm. To me, I still want to see, are we able to intervene on it? Is it just a matter of avoiding antibiotics because they're doing better, or can we modify outcomes based on repopulating the microbiome, fecal transplants, things like that? Thankfully, a lot of the work being done, as you know, through Sloan Kettering and others now to find that out, but also intrigued by this, can we modify T-cell function? Because again, this is in CAR T, almost a kind of encapsulated model of immunity against cancer. What's to say that that doesn't work in the rest of them where we know that T cells are just as effective? And so that's the thing I'm excited about. If they really find that this makes T cells more effective against malignancy, do they need to be genetically modified to have that effect? Probably not. And we'd be able to see it in all these other cancers that we know immunotherapy is helpful for. So great question.
This has been like a decade ago when I was working in BMT, and just really we assessed sedentary behavior, and it wasn't about getting patients to exercise, but like time sitting in this sort of allotransplant setting, just on how they did post-transplant, and a lot of it was GVHD. And so I'm just always curious of like, you can't have one without the other if there's sort of that other side of things. And then my last addition, since we have a minute, is then what do we tell people now? Because I do think it is powerful to at least give them less of the advice of, well, just eat whatever you want, do whatever you want, and give them a few nuggets of something that really can just drive the needle forward in a accessible way. So those are my two questions.
Yeah.
And then I'll shush.
No, that's great. That's great. That's fantastic. So two things I would say is, especially in the immune suppressed population that I deal with, kind of, allotransplant, CAR T, things like that, I don't encourage the probiotic supplements. The dose of it is too high. There are examples of it causing bacteremia and infection. Not a lot, but occasional. But I am a big proponent of just kind of the yogurt, the kind of smaller dose of repopulating the microbiome. So that is one of the things that I suggest, and just say find some way to get that in. And it's not only yogurt. There's other things that kind of have that moderate level as opposed to the huge, huge dose. The second is in terms of the physical activity, I agree across all malignancies. Physical activity is one of the things. Patients tolerate chemotherapy better, survival's better. and transplant's no exception. Prehab even has been shown to improve transplant-related mortality. So basically the few weeks ahead of time, just getting them to move like almost your little goals. All right, wherever you're at, just get a little bit better, right? And that's really the goal of prehab. And I think that for transplant, it's a high impact, high resource kind of a thing. And so it gets some of those studies done. Do I think that the same would probably be true for a lot of the other malignancies? I do. And so how do we start a habit of, all right, I get a patient in, and maybe they watch your exercise routine each time, but somehow just move from wherever they're at to a little bit, a few steps forward, because it improves outcomes across the board. It's accessible, it's low cost, it's got a lot of other benefits, and it's a really big proponent of it. Now, in terms of the question of graft versus host disease, such an interesting pathophysiology, right? Because it starts with tissue injury. And tissue injury then leads to allogeneic exposure. Allogeneic exposure leads to more tissue injury. And so it's that genesis of having some tissue injury that contributes to it. And so oftentimes and historically, that's why myeloablative conditioning is associated with more GVH than non-myeloablative conditioning, because there's more tissue injury. But when I think about sedentary patients, right, we all know that if they lay there long enough, right, they're going to get a decubitus. So we know that there's tissue injury happening when you don't move. The body, will just, again, digestive health when you move. More patients are constipated if they aren't moving as much. And so, so there's actually a lot to say about that initial hospital stay and how do you avoid to any tissue injury during the period when that new immune system is repopulating and you're getting that first potential alloreactivity. And so that's where I think it probably is. Again, have the studies been done, randomized, things like that? No, not yet, partially because it's such just a low hurdle to get through, and it's just, but if it got all of the attention that I think it could, if it was done in the same way, and you show these mortality benefits, right, everybody would be doing it. And so I do think these are the things that we just need to, with our teams, continue to just promote and say, when we're admitting somebody to the transplant, ward, we say, all right, you're going to be in there. It's encouraged, almost required that you're up and about, moving around, things like that. And so that's the expectation. We've got a gym there on the hospital floor. I think more and more hospital floors need an actual space to, get some movement in, or at least something to bring into the room, even those little just kind of wheel around the mini bike things, stuff like that. So yeah, great question. Any others? Yeah.
Great talk. Thank you so much. So just forward-looking, I think in the clinic we still use, older tools like the IPI score, for, prognostication and risk stratification, and then even for toxicities, novel toxicities, we have, maybe not the best. Oh, thank you so much. Perhaps we don't have necessarily the best ways of predicting some of these toxicities. How do you see AI, multimodal models, new ways of doing computational biology, computational pathology? How could this sort of enhance what we're already doing right now in the clinic?
Yeah, great question. I think that for anybody that's in the clinic now, you know that there's just an onslaught of information right now, and it's hard to process all through it. We joke a little bit because for myelofibrosis, for example, there's DIPS, and then there's DIPS plus, and then there's DIPS molecular, and then there's all of these different things that can factor into it. And when you're seeing a patient, are you really going to be able to go through and type in, all right, here's the variant allele frequency? And so I think that a lot of our prognostic tools, we have the information, and it's great to do it in a publication, but in real time, it's really hard to employ. And so I think, to your point, getting some, and it wouldn't be a complex one, right? It could just be extract these data points and bing, give me a score. This isn't one where it's, I hope it keeps getting better and better. Summarize this whole medical chart for me in like a one-page summary. I'm looking forward to that. But I think that, so for the prognostic scores for predicting toxicity, and I think for predicting transplant-related mortality, right, a lot of these things that pull from so many different places, I think just the speed of it to actually use the information we have already is step one. Step two is, once we realize that that's effective, We can pull from like hundreds of different data points, and then we get even better at it, because I think right now, we laugh about the molecular DIPS plus, right? If you're going to go DIPS plus 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 and, you know, have 50 different, you know, things you need to track down, nobody's going to use it, and so nobody's done that study. So I think that as we get faster at processing it, it's just going to be even better and more accessible, especially for the patient in front of you. Great question. All right. Appreciate it again. Thank you.